Hello. Hey, welcome.
Hello.
Hi there.
Thanks
Uh,
for me.
we'll just give it a few more minutes. Super excited to have you here.
Happy to be here. Thanks for having me.
Yeah, people are just logging on right now. I think we have a good number. Some people might continue to file in, but we can go ahead and get started just in the interest of time. So good afternoon, everybody. I'd like to introduce Dr. Andrew Crafson, who's a clinical associate professor of endocrinology and internal medicine here at Michigan Medicine. He did his medical school at Chicago Medical School, University of Health Sciences, internal medicine residency at Northwestern University, and his endocrine and metabolism fellowship here at the University of Michigan. Dr. Crafson specializes in treating patients with excess weight/obesity, in addition to seeing patients with general endocrinologic conditions. He was inducted into the Clinical Excellence Society in 2021. He is the director of the Weight Navigation Program, director of the Post-Bariatric Endocrinology Clinic, and assistant director of the Weight Management Program. His research focuses on gaining a better understanding of obesity causes, consequences, and treatments. And in addition to all of this clinical and research work, he is actively involved in medical education and is the Associate Program Director for the MEND Endocrinology Fellowship. So Dr. Crafson, welcome, and we are excited to learn from you.
Thanks so much, Anita. Really appreciate the invitation. Happy to talk about an area of medicine which I'm quite passionate. So we'll get started. And I thought, I've given a lot of talks about the medications themselves, but I thought I'd change the perspective a little bit to talk about our role as team members as we try to treat our patients with obesity. And no disclosures, I probably should work on that, but none for now. And then thank you for the kind introduction. So I don't need to say anything more about myself other than I am in the trenches. I am seeing these patients. So definitely have the clinical experience as well as some of the research. So how do we as teams contribute? We really, at the end of the day, are advocates for our patients. And so I'm going to go over through this talk, some of these little aspects of how we contribute. So what a year it has been. Science magazine declared that incretin mimetics were the breakthrough of the year. So this, of course, has been to much fanfare in popular media and with our patients. It's really been unprecedented, the impact of these injectable anti-obesity medications. So this is a bit of a rhetorical question. I'm not going to set up a poll or anything, but which of these can be true if weight control medications used as a primary treatment tool? A, can achieve a goal weight. B, can decrease food noise. C, can help manage hunger and or cravings. Can enhance the efficacy of diet and exercise efforts. And of course, all of the above can be true option. So on the other side, what a year has been, it has been kind of overwhelming. All the messages that we are receiving, that our patients are receiving, and also communicating to us that the media is putting out, there has been unbelievable attention on this area. And so I pose this: what else can be true about use of medications? Can they exacerbate an eating disorder, result in excessive muscle loss, disconnect patients from their primary care provider, result in lower weight, but also malnutrition? So as these leading questions you can discern from these leading questions that the answer would be E for both the positive side as well as the not so positive side. So these can be a double-edged sword. So it is also important for us in medicine to be holders, keepers of the history, that this did not come out of nowhere. We did get to this place from somewhere, and how did we actually get here? It is appalling to do a Google search of old things that have come before. But what we do know is that we have created and fostered toxic views on weight. We have conflated weight with morality. Gluttony has been brought up a lot. We've talked about willpower and character. We've really built an obesogenic environment that fosters excess weight. We have resisted efforts to gain better understanding of weight, sometimes willfully so, or been grossly negligent to try to increase our understanding of weight. We've also been quite hard on those who've been affected by both genetic and environmental factors. And of course, we've developed an industry that benefits from all of this toxicity. So as part of the medical community, we really should recognize our own culpability, grieve for fostering prejudice and injustice, acknowledge the mistakes, try to understand the issues better and have goals, and then really try to help our patients. So looking back, we have seen all the miscommunication, the prejudice has been built, the crazy things that have been offered for weight treatment for folks who are desperate to have better control of weight. As you can see, cigarettes offered as a weight control treatment, over-the-counter stimulants. This was a very unfortunately named product called AIDS, which then was actually popular for a time and then fell out of favor in the 80s. And you maybe can guess why in the 80s AIDS was not a great name for treatment. And sugar is that therapy, as you know, that keeps your energy up and your appetite down. So it is no wonder that the public, individuals, medical community all have been part of this confusing morass that's hard to sort out. So our past helps to teach us that we didn't understand the mechanisms of weight change. We didn't really apply scientific rigor to examine treatments. We left responsibility of treatment really to the non-medical sector, the commercial sector. We didn't provide a good basis to provide medical training, and we produced poorly informed graduates. And I certainly was one of them, I can say. Fortunately, that has been hopefully fixed. But what we know is that society has actually had a much greater impact on healthcare and our care of individuals with obesity. And this was quite literally the messaging that I received in medical school. So I graduated from medical school in 2004, and I would say that this would sum up the advice I was told to give my patients. However, things have advanced, and now we realize certain things, and we also start to know the things we don't know. So we do not fully understand the impact of our environment and obesity. And so this complicates efforts to make public health policy. So this can be the problem when we want to do these very expensive interventions or widespread interventions, but have not done a great job of studying to see in a pilot way how well they'll work. Like you could institute a sin tax, like on sugar sweetened beverages, but did you actually study to make sure that that will have the outcome that you want? We do know that environmental factors are certainly impacting our genes, the epigenetics of it all. So you may be aware that of the Dutch famine in 1944 and the fact that the cohort of progeny that resulted from that time were actually followed medically. And we know that women, the children of women who were in the first trimester of pregnancy during the famine had a greatly increased risk of obesity and type 2 diabetes. We know that there's a complex array of genetic, neurobiologic, and hormonal factors that come into play with weight control, and that there is not a level playing field for those with obesity and those without. And we know that weight loss and weight loss maintenance are challenging due to numerous factors. So based on the progress of science and our understanding, we have finally come to the place where obesity has been classified as a disease. But it may or may not surprise you to learn that that was only 11 years ago that the AMA made that designation. So what we hope is that our treatment of patients with obesity follows the same rigorous medical principles as treatment of other chronic conditions, and that the better understanding scientifically will allow for more individualized treatment, but that multimodal therapy will be necessary in almost every case due to the complexity of the condition. I'm not going to spend too much time here. If there are questions about this, we can go over it, but just wanting to say that we in medicine also need to have a stance in culture. So there are some things that are happening in a positive way about how we consider individuals with overweight and obesity, but some of that conversations aren't always in alignment with medical principles. And so there are things that we can learn from those in other camps and other ways of thinking, but there are also things that we need to stand against, which would be calls to say that there is no safe way to lose weight, or there are no medical reasons why anyone should lose weight, or that we are trying to be discriminatory or erase all individuals with overweight or obesity. But if we don't know those conversations are taking place, then we can't address them in meaningful and productive ways. So I talk about as if this training were in the past. For many, it continues to be the present about the extent of what is happening. So we in our group wanted to understand what is actually happening with our patients with overweight and obesity. And so we looked at about 150,000 patients at Michigan Medicine in the primary care group. And what we found in 2019 is that only 7% of our primary care patients who have obesity utilize any weight management treatment. And that's the whole range of things from dietitian referrals to the weight management or rewind program, bariatric surgery, many different things actually, or any anti-obesity medications. But what we also found is that if someone was on any of these treatments, there was a exponentially higher chance that they would be able to achieve or exceed 5% weight loss. We also wanted to find out from our primary care colleagues what are the barriers to optimal treatment of patients with obesity. And we found no shockers here, really, that there were feelings of lack of training, visits were too short, there were competing clinical demands, but also that the system was really failing us and not giving us support to longitudinally support our patients for chronic disease management. So what do we do about the fact that there are these medical differences between individuals with obesity and those without in terms of how they actually navigate weight control, hunger, and cravings? We really want to then look at what are the differences or what are the issues involved in any given patient who's in front of us. And that's where we need to do an appropriate needs assessment and try to figure out between these different buckets. Now, this is an oversimplification, but these would be major categories where we would want to determine if there is uncontrolled mental health concerns. Really, that's the stop point there. We don't then say, all right, ready for bariatric surgery. We have some groundwork to do to make sure that there is mental health stability before proceeding with actual weight loss treatments. Furthermore, if someone is found to have an eating disorder, and eating disorder comes in many different forms, we would want to make sure that that was addressed again, before instituting a dietary pathway or some other intervention for weight control. We also want to know what is it that we're giving to our patients that may be weight positive, whether it has to do with psychotropic medications, whether it has to do with our anti-diabetes treatments, and so on. There are things that we could look at to say, well, maybe you could be on a weight negative alternative rather than a weight positive medication. We also need to know, the patient that you have who has never really heard about carbs, fats, or protein in any meaningful way will be treated differently than someone who's like, well, I read 15 textbooks about diet and nothing works for me. They need to be approached differently. And so if the bucket is that we need to just fill up a baseline level of knowledge of dietary and health literacy, then that's going to be, again, a different intervention than someone who is been around the block a few times. And then hunger and cravings is something that we're going to talk about in more detail. So a team is critical to try to fill these buckets, as I was alluding to. And then the members of those teams are going to be overlapping, but there may be those who bring specialty expertise to address certain issues. So let's talk about hunger and cravings, because that's really the of the moment discussion that's happening with injectable weight loss medications. So here's just a brief history of these types of medicines. As discussed, we had gained insight into the metabolic and hormonal neurobiologic control of weight and had a better understanding about the metabolic circuitry as well as the reward circuitry. And in explorations of these of the neurobiology, as well as our explorations of control of diabetes, the incretin effect was first identified in the 80s. So we have these hormones, such as GIP and GLP-1, that respond to the food that we eat. And they respond in a much more pronounced fashion to carbs than to fats or proteins. But once they are stimulated, they help terminate eating behavior, promote satiety, decrease gastric emptying, but also as pertains to diabetes management, they help enhance insulin secretion. So what we know is that for those in good health, the incretin hormone effects spike in response to oral glucose. Interestingly, you do not have that effect in response to IV glucose. So you need the oral enteral effect to stimulate the hormone. But in disease, the hormone levels could be high, but they may not work super well for that patient as the individual. And you can think about that as analogous to insulin resistance. You can have incretin resistance, so not just a deficiency per se. And so if you were to have a patient with prediabetes or with obesity, you would see a blunted response to the incretin effect. And that would be additive if they have both dysglycemia as well as obesity. So I bring this up also because it is not that these injectable medicines are going to be the panacea for everyone, because they don't fix the underlying problem. And like I said, it's not just a matter of deficiency, but replacing it back does seem to be helpful for a number of individuals. And exploration of multi-hormone therapies will be, the next step forward, has been the next step forward. So there are many different names by which these medications go. GLP-1s, people talk about them, incretin mimetics, and then this newest term, NUSH. So these are nutrient-stimulated hormones, and is an umbrella term that would cover multiple different things, such as GLP-1s, GLP-GIP agonists, dual agonists, amylin, mimetics, glucagon would be another one. And so, as you can see, it's been almost 20 years since the first option was available on the market. So Byetta exenatide, came out in 2005. And I remember that. I was a resident at the time. And so many of us have been prescribing these medicines for almost 20 years. And so it is a bit a strange moment to have everyone in the media and the public act like this is just out of the woodwork, but clearly it is not. Now, I don't know if this term will catch on. It's certainly in the circuit of the national meetings and things. In actuality, we really have 4 treatments that are in active use, and most of the others have fallen out of favor. So how well do these medicines work? And you may be aware that they work pretty well. So we have outcomes trials for type 2 diabetes, for secondary prevention of cardiovascular disease in folks with or without diabetes. And certainly you can hit on many different cardiometabolic conditions. But of course, the attention is most being paid toward its effect on weight. So it is really not an overstatement to say that use of these medications have been transformative for a number of patients. We can look at the pre-incretin era. Before 2012, we really had very, very few options. So 2012 marked a watershed moment where we started to have effective oral therapies, including Qsymia and Contrave. But you can see that the percentage of patients achieving at least 5% weight loss was quite good with Qsymia, was kind of so-so with Contrave. All of these patients participating in these studies are also conscripted to moderate intensity lifestyle intervention. 2015 was the first time an injectable was approved for use for weight, and that was Saxenda. And Saxenda, in clinical practice, we found that for some people it was practically miraculous. They loved it. But overall, the results actually were not as good as Qsymia. Furthermore, there were barriers to uptake of this therapy, one being that it was a daily injection. Is that it's a daily injection. So Wegovy really marked a turning point because you have over 90% of individuals who are on Wegovy in the clinical trials would achieve at least 5% weight loss. And then Mounjaro, now known as Zepbound for use for weight, had results that were even better. And this was our first dual hormone agonist. So you can see for Wegovy, a third of people would lose at least 20% of their weight. And for tirzepatide, you have almost 40% of individuals losing at least 25% of their weight. So certainly knocking at the door of bariatric territory levels degree of weight loss. So we then in medicine, our goal is to help direct and guide our patients and think about these options and think about using them effectively. So we want to guide the narrative. It can quickly spiral into what we're seeing in the media, which is, oh my goodness, all these Hollywood celebrities are just trying to be thin. And you just hear a lot of chatter that is actually not constructive for this. And then a direction of really focusing on weight. But what we should really help is to determine what are actually the goals that we and our patients have for each other, and how can we focus more on health rather than weight itself. And we need to get to know what our patients' goals are and to figure out how they align and how they differ and how we can guide them toward a health-focused narrative. So weight loss, yes, it is a means to that end, but it certainly does not encompass the whole story. As you may know, it is only modest degree of weight loss that is necessary to achieve meaningful clinical health benefits. And so that modest goal could be appropriate for the majority of our patients and is certainly worth pursuing. However, what we are doing now is not working, and it does not even achieve this modest goal. So there are countless studies about how this general lifestyle advice is just ineffective for even this modest goal. So what do we have here at the university to guide our patients? There are actually quite a number of programs here, as you may know, but as you may not know well. And each program has unique features that may match a patient's individualized situation and or needs. So I've just included these slides just so you know that there's actually a website that I created. They didn't allow me to make it as fancy or pretty as I wanted to, but it has some of this basic information as well as links to some of these websites. And then there are other programs that are not necessarily going to be the treatment programs, but they're going to be evaluation of complications of excess weight that can be helpful. So in terms of comparative efficacy, this is a this is a sensitive topic, but I would say in broad strokes that when we think about later stage disease, more severe disease, then sometimes we are delaying treatment of really effective treatment by starting a little bit too gentle early on. And so it's helpful to know what are the treatments that really are targeted for severe obesity classes, class 2, class 3, and beyond. And so we know that only 2% of eligible patients are actually utilizing bariatric surgery. We know that things like meal replacement, such as the weight management program, the Rewind program, are going to be more highly effective than conventional dietary interventions. But just know that at all range of the spectrum, treatments can be helpful. And so, as I alluded to in the beginning, when we did that study, really exposure to any treatment is better than exposure to no treatment. So again, don't go around waving this to everyone. I think some of the programs might dispute some of this, but I was trying to base it off of actual data. And so we know that general dietitian visits, there's limited data on that. It's when done in a very general way, it's not that effective for actual weight loss. Commercial weight programs, there's some good data. So 3 to 5% loss of weight would be really expected by 12 months. I don't know if anyone from connected to mHealthy is here, but I would say mHealthy is really not a weight loss intervention. It's a health enhancement intervention. Weight control medication, we talked about that already. Metabolic fitness would be a program that's really meant to help with cardiopulmonary health, and weight loss can occur, but it's not the primary focus per se. And their own data would suggest that 5 to 10 pound weight loss would be more common of this 24-week program. Endoscopic bariatric therapy would be associated with about 15% weight loss. The meal replacement intensive weight management program, that would be 10 to 20% weight loss. Bariatric surgery would be 20 to 40% weight loss. This really just talks about, we think we're doing a good thing by referring to dietitians, and I say dietitians are essential, but they're often underutilized or misutilized. And by that, I mean, a lot of times where we start and end is this general nutrition kind of advice session, and that is actually not well received by patients and doesn't really help with weight loss. And so that can be at the start to help fill that dietary and health literacy bucket, but it really isn't the end for actual helping with weight loss and weight loss maintenance. There are many different strategies that do have evidence to support, and so that does create flexibility to help our patients find a intervention that may be resonant with them. And it's important to realize that all the weight control medication studies, as I alluded to before, did have concurrent diet and exercise intervention with them. I'm going to skip this just really to show that with medications, more intensive lifestyle intervention actually greatly enhances the efficacy of the medication usage. And then special dietitian expertise is a good match for certain things like post-bariatric surgery or procedures for individuals with certain conditions. Mental health always gets short shrift, right? And today will be no different. I'm really just pointing out this really disparity between how important we say that it is and how many resources we actually have. But there are things that we should do in the clinic in any kind of both the PCP office, but also in obesity treatment programs. There should be screening for untreated or undertreated mental health issues. We know that those will significantly interfere with weight change efforts, and that there are screening tool questionnaires that can help facilitate that process and standardize it. We also shouldn't think of the mental health component as the weight loss intervention. It really is providing the foundation from which we can springboard to help with weight loss. There are evolving needs through the weight change process. So some things can bubble to the surface during the process. And so there may be differing needs that may happen. Something that we encounter a lot is that folks do equate weight loss with improved happiness and fulfillment. And unfortunately, that is not going to be the void. The void in our life can't just be filled with weight loss. And so there can be issues trying to deal with that, oh, I'm lighter, but I'm not, happier. And we need to help set expectations in a meaningful and helpful way. And we also need to recognize that significant changes of weight have ripple effects that affect other people around. And so we need to watch for how that may affect relationships. We also screen for domestic abuse when that can happen, especially when severe jealousy is generated due to weight change. We need to watch for transference of coping behaviors and or addiction. Support groups are helpful. They're definitely helpful, but they really do need facilitation. A support group that has no facilitation can devolve into something that's very not constructive, and it doesn't replace when someone really needs one-on-one therapy. So unfortunately, there are few resources. Even at an institution like ours, there are very, very few people who have expertise in this area, eating issues and obesity. We do need to advocate for more on this area, but we do try to compile a list of local resources so that we do have something at the ready that we can provide patients. So exercise is something that's helpful to talk to patients about, is that exercise and physical activity are two sides of the same coin. So the physical activity would be the ADLs that we do, what's incorporated into usual work and chores, and exercise really then would be getting heart rate up for a sustained period of time, stressing out our muscles, challenging them, etc. So that, because our patients, all of their definition of exercise and activity differs, and so it's good to set the stage for what we're talking about. So I don't want you to get the message that I hate exercise or think exercise is worthless, because that is not it. It is just not a great weight loss tool. But it does so many other things that really we want to try to divorce in some ways this idea of weight loss and exercise, because how many millions of people are in gyms not losing weight? We don't want them then to stop exercising because there's like, well, I'm not losing weight, so why am I putting in all this work? Because what they're doing is staving off frailty, improving cardiopulmonary health, improving insulin sensitivity. There are many different reasons to exercise, irrespective of weight. But it is helpful to preserve lean body mass while losing weight, and it is helpful to maintain weight, a reduced weight state. So in our roles, we want to know the options that are out there and try to help our patients determine appropriateness of different therapies. We want to help them navigate the financial mess that is all around us. We want to try to set treatment expectations and what success actually means, provide excellent teaching, supervise and provide longitudinal support, and be able to tailor treatment when things are not going the way that we want. So if the medications that I presented, or as they've come into the public consciousness for the first time, really in the last 15 years, what I've noticed is that people want to be what I want to prescribe. So a lot of times, we're prescribing insulin or antihypertensives, and folks don't sort of feel a benefit on a day-to-day basis. And so they begrudgingly take it, or they commonly don't take it. But this is certainly an alignment where I'd want them to be on it and they want to take it. And these are just some compilation of comments that I've heard from my patients. So, if they help with diabetes and the heart and weight, should we just put them in the water? But yet, what we're actually seeing reported in the literature is that there is a high real-world discontinuation rate of these medications by 2 years, and then much higher than they were reported in the clinical trials. And this is really true for any weight control medication. There's just a high discontinuation rate. So why would this be happening? What are the problems with these medications? So some may say, well, people don't want to take a shot. And I will say, meh, I mean, it just really, if you actually show someone one of these injectors and do a demonstration, I would say in the last 15 years, there's probably fewer than 10 patients I couldn't convince to be on an injection of some kind, whether it be insulin or these, if I really thought they need to be on it. Like, you can convince people and show them that it's not a big deal. But with this in mind, there are folks who are trying to formulate, these are difficult large peptide molecules, and so oral formulation has been challenging, and they are coming up with strategies to address that. So that is coming in the near future. Side effects is certainly an issue. What we know is that a large swath of our patients will experience side effects on these medicines. Some that are mild, but others that are certainly not trivial. When given appropriate management support, guidance, and preemptive counseling, you can get folks through these issues in the majority of cases. But in this age of, shall we say, pill mills or people just getting prescriptions online, without this kind of guidance, you're going to run into a lot of trouble. Costs, that's certainly what we're hearing about these days. We know that these are very expensive medicines, $1,000 a month out of pocket, at least. Coverage is excluded for many based on their insurer, and more insurers, such as Mayo Clinic, recently instituted a $20,000 lifetime benefit cap on these injectable medications, and others are considering, for example, a 2-year cap on therapy. Prior authorization has been the bane of all existence, step therapy, patients with deductibles, donut holes, for example. Shortages. Since Wegovy came out, there's been basically about 3 to 4 months total. So it came out in 2021, and in that time, there have been only a few months where you've been able to get any dose that you wanted. And it's really been highly restricted and in shortage ever since. There have also been unintended problems: malnutrition, eating disorders, frailty, sarcopenia. A hot topic right now has been the muscle loss concern, especially for our vulnerable populations. The data is mixed and inconclusive, but the pharmaceutical pipeline is now being filled with things that would help preserve muscle function in the midst of weight loss. Another reason we want the team involved, because do we need to have these patients all on medications to accommodate or ameliorate the effects of the medication, or do we have more people involved in the lifestyle intervention and the exercise and physical activity support? So I'm gonna skip this for time purposes. So how can we be helpful? Really, we have this opportunity now in this age of more effective treatments, more options, to really look at systematically how we utilize these treatments, how do we implement them, how do we accommodate things such as loss of coverage of a medication or a cap on that, what it would be the off-ramp plan, how do we help our patients navigate the cultural conversation, and how can we be at the forefront of determining best practices? So one example from our own institution would be something called the Weight Navigation Program. I hope you have heard of it. If you hadn't, then let me tell you more. So I was approached back in 2018 to try to address a problem where you have patients and physicians who don't understand well the options that we have at the university. And then we have patients who don't fit into the nice, neat treatment silos, and there are gaps in care. So we created a program to try to embed obesity expertise at every primary care site to allow for appropriate evaluation and management of folks with overweight and obesity, to help them navigate our system, as well as to look at what are the care gaps and try to be part of the solution to address them, and to develop a robust research program to investigate all of this. So the intervention, we have primary care physicians with obesity medicine training who are then identified and then placed as weight navigators at their primary care site. And we have developed population health management tools to help support the endeavor. So an example would be they would get a full 60 minutes to, so their own colleagues at that primary care site would refer to them, and then they would have this visit where they have an hour with the patient to go over their weight and medical history, to talk about the different options that are in the system. And the physicians who are in our program, who are the navigators, have done, you could say, a training protocol where they have rotated through the various weight treatment programs. So they know them well, they know the inclusion exclusion criteria, help navigate them toward a pathway, and then we can follow them through the process. An example, if we elect to send them through the weight navigation treatment arm, would be initiation of medication, titration of the medication, with the intention that once stability is achieved, that the primary care physician, the original primary care physician, will then assume prescription responsibility for the patient. So how things started, how it's going, we now have expanded in family medicine. So if someone has a Michigan Medicine family physician, they can place a weight navigation family medicine referral, and they could be seen by one of the 3 participating physicians. In internal medicine, we started a year ago, and we had 2 original sites, and we have another couple going on online soon, and with talks to continue expansion. And then endocrinology provides the stopgap measure for those who don't fit into those categories. It can be referred to endocrine, though we have the limited capacity, the least availability. And we've seen almost 1,000 new patients in the weight navigation program. So in summary, obesity medicine actually is quite hard, but there are effective treatment options, and they are exciting. But we should learn from our history to understand how did we get here and where can we go. Medications do not replace teams, they illuminate the value of teams, and we still have much to learn. So I will stop here and then open up for questions.
Thank you so much. That was excellent. I think there was one thing in the chat. Anything sleep psychologists should know about Ozempic?
One of the nice things about incretin therapies have been they are relatively agnostic in terms of psychotropic medications and mental health. There have been some reports in the media that, oh, does it increase suicidality? But when you look at the data, there is no evidence to support that. But in terms of what we know about something like nighttime eating syndrome, something like Ozempic isn't necessarily the treatment of choice for that. And so there are plenty of folks that I have who are on incretin mimetics, and they have almost no appetite, and yet they're still eating at night. And they're still getting up. I saw a patient just 2 days ago who was getting up at night and then eating, but not hungry. And it seemed like had not been in touch with sleep medicine for quite some time. I had concerns that their sleep issues were not fully addressed. And so that was my intervention, was to say, you need to plug back in because, you're on the max dose, your hunger and craving levels are quite low. We're not quite getting at the full root of the problem that you're experiencing. So I hope that at least partially answers your question.
Great, thank you. Does anyone else have a question? Feel free to unmute. I have a question for you. You mentioned that just kind of basic education, I don't remember the words you used, are really insufficient. And I think that's probably what a lot of us do, just put it out there that that obesity may be a contributor to obstructive sleep apnea, for example. But, understanding the constraints of the system, primary care is taxed for time with patients, your clinic is busy. What can we do to kind of more helpfully inform patients about ways to get started on addressing obesity?
Yeah, I think first asking the question about what the patient thinks would be helpful for next steps for management. What are ways that the system could support them better? We did create the weight navigation program to be sort of that that overall safety net, so that if the question was asked, I think, in the chat about, is it only for PCPs to refer? What I would say is, if the patient has one of those PCP situations that fits in with what we have for current coverage, I would encourage them to ask their PCP about the weight navigation program. However, you could place a referral, particularly to endocrinology, and we could reroute it if needed. But if you're like, oh, that's Brian Brophy's patient at Briarwood, just tell the patient, could you ask Brian Brophy about the weight navigation program? And then they will, go from there. Like he would likely put in the referral, no problem, and go from there. And then they would get information about the intention of the program, and there would be someone to work the work queue.
Great, thank you. Any other questions? Okay, I don't see anything else in the chat. Nobody else's hands up. Thanks for sharing that website. I grabbed that and put that in the chat if anyone was able to see that there. But thank you again, Andrew. This was wonderful, and we really appreciate you sharing your expertise with us.
Thank you so much.
Thank
Hope you all have a great day.
Thanks, you as well.
Take
All right,
care.
thank you.
Bye-bye.